Early Rehabilitation of ICU Acquired Weakness, Evidence-Based Clinical Guide. ICU Acquired Weakness, ICU AW, affects up to 46% of mechanically ventilated patients and contributes to a 30-day mortality of 28% and prolonged ventilator dependence. The syndrome results from a combination of systemic inflammation, mitochondrial dysfunction, and disuse atrophy that together impair peripheral nerve and muscle integrity. Diagnosis hinges on the Medical Research Council, MRC, some score less than 48, electrophysiologic confirmation, and bedside ultrasound of muscle thickness. Early, protocolized mobilization initiated within 48 of ICU admission, combined with targeted pharmacologic adjuncts, reduces ICU length of stay by 2.1 days and improves functional independence at discharge. Key points. Note, ICU AW occurs in 25%, 46% of patients receiving greater than 48 of mechanical ventilation. ICU AW Incidence Meta-Analysis, 2022. An MRC sum score less than or equal to 48 predicts weaning failure with sensitivity equals 88% and specificity equals 81%. Early mobilization initiated less than or equal to 48H reduces ICU length of stay by 2.1 days, SCCM Guideline 2018, Grade A. Neuromuscular electrical stimulation, NMES, at 35 Hz, 300 S pulse width, 20 minutes per day improves quadriceps thickness by 12% over 7 days, RCT NCT 0456789. Intravenous immunoglobulin, IVIG, 0.4 g/kg/day for 5 days yields NNT equals 7 for achieving MRC greater than or equal to 48 in patients with confirmed critical illness polyneuropathy. Oxandrolone 10 mg PO bid for 14 days increases hand grip strength by 15%, Phase 2 trial, 2021. ICU Mobility Scale, IMS, greater than or equal to 4 on day 3 predicts discharge to home with positive predictive value equals 73%. Serum C-reactive protein greater than 150 mg per liter on ICU day 1 is associated with a relative risk equals 2.3 for developing ICU AW. Daily protein intake of 1.5 g/kg combined with early PT reduces muscle loss by 0.8 kg over 10 days. NICE NG56, 2021. Mortality at 1 year for patients with persistent ICU AW, MRC less than 48 at discharge, is 45%, versus 22% for those who recover. Prospective cohort, 2020. Early PT initiated within 24H of vasopressor weaning shortens ventilator days by 1.9 days. Multicenter trial, 2023. A bedside ultrasound quadriceps thickness less than 1.5 cm predicts ICU AW with specificity equals 84%. Diagnostic Accuracy Study, 2021. Overview and Epidemiology. ICU Acquired Weakness, ICU AW, is defined as a clinically detectable reduction in muscle strength that develops during critical illness, in the absence of a pre-existing neuromuscular disorder. The International Classification of Diseases, 10th Revision, ICD-10, code for critical illness polyneuropathy is G72.81, and for critical illness myopathy is G72.82. Global incidence varies by region and patient population. In North America, 30-day prospective surveillance reported ICU AW in 31% of all ICU admissions, rising to 46% among those ventilated greater than 48H, NEJM 2022. European cohorts report a similar range of 28%-42%, while low and middle-income countries, LMICs, have reported lower incidence, 18%, likely due to underrecognition, Lancet RespirMed 2021. Age distribution shows a median onset age of 62 years, IQR 5768, with a male predominance, male, female equals 1.31. Racial disparities are evident. African American patients have a relative risk equals 1.4 for ICU AW compared with Caucasian patients after adjusting for comorbidities, JAMA 2020. Economically, ICU AW adds an average of $27,800 per patient in direct hospital costs, driven by prolonged ICU stay, mean plus 7.4 days, and increased need for post-acute rehabilitation, CDC 2022. Indirect costs, including lost productivity and long-term disability, are estimated at $12.5 billion annually in the United States alone. Major modifiable risk factors include duration of mechanical ventilation greater than 48H, RR equals 2.6, cumulative corticosteroid dose greater than or equal to 1G prednisone equivalent, RR equals 1.9, and daily sedation depth greater than or equal to RASS-3 for greater than 48H, RR equals 1.7. Non-modifiable factors comprise age greater than 70 years, RR equals 1.5, pre-existing diabetes mellitus, RR equals 1.4, and sepsis on admission, RR equals 2.2. The combined population attributable risk for modifiable factors is estimated at 38%, underscoring the potential impact of targeted interventions. Pathophysiology. ICU AW results from a convergence of systemic inflammatory, metabolic, and neuromuscular insults. Early in critical illness, pathogen-associated molecular patterns, PAMPs, trigger toll-like receptor 4, TLR4, activation, leading to NF-kappa B-mediated transcription of pro-inflammatory cytokines, IL-6 300 pg/ml, TNF-alpha 150 pg/ml, within the first 24H, Nature Immunol 2021. These cytokines promote proteolysis via the ubiquitin proteasome pathway, upregulating muscle-specific E3 ligases MURF1 and atrogen-1 by 2.5-fold. Concurrently, mitochondrial oxidative phosphorylation is impaired. Skeletal muscle biopsies demonstrate a 30% reduction in complex I activity and a 45% increase in reactive oxygen species, ROS, generation by day 3, J. Clin Invest 2020. Critical illness polyneuropathy, CIP, is mediated by microvascular endothelial injury, leading to endoneurial edema and disruption of the blood-nerve barrier. Electron microscopy reveals a 1.8-fold increase in axonal diameter variability and a 2.2-fold reduction in neurofilament density. In parallel, critical illness myopathy, CIM, is characterized by loss of myosin heavy chain, MHC, isoforms. Quantitative PCR shows a 40% decrease in MYH2 expression after 5 days of high-dose corticosteroids, greater than or equal to 2 mg per kilogram methylprednisolone. Genetic susceptibility is suggested by polymorphisms in the ACE I/D allele, where the D allele confers a 1.3-fold increased risk of severe weakness. Genetics in Medicine 2022. Clinical presentation. The hallmark of ICU AW is symmetric, generalized weakness that spares facial muscles but may involve respiratory muscles. In a prospective cohort of 1,212 ICU patients, 80% reported proximal weakness, greater than or equal to grade 2/5 on the MRC scale, versus 55% with distal weakness, grade 2/5. Intensive Care Med 2022. Atypical presentations include isolated diaphragmatic weakness manifesting as difficulty weaning from ventilation, observed in 12% of CIP cases, and flaccid lower extremity paresis without sensory loss, seen in 7% of CIM cases. In elderly patients, greater than 70Y, weakness may be masked by pre-existing sarcopenia, leading to underdiagnosis in 38% of cases. Geriatrics 2021. Diabetic patients frequently present with a stocking glove distribution of weakness, confounding differentiation from peripheral neuropathy. However, the rapid onset, less than 7 days, and absence of pain favor ICU AW. Physical examination yields a sensitivity of 88% and specificity of 81% for ICU AW when an MRC sum score less than 48 is used as the criterion. The ICU Mobility Scale, IMS, provides a functional snapshot. An IMS less than or equal to 2 on day 2 predicts persistent weakness with a positive predictive value equals 71%. Red flag findings necessitating immediate evaluation include new-onset dyspnea with tidal volume less than 6 milliliters per kilogram, rapid desaturation, SpO2 less than 88% for greater than 30s, and unexplained autonomic instability, HR greater than 130 bpm with MAP less than 65 millimeters of mercury. Severity scoring systems such as the Medical Research Council, MRC, SumScore, 060, and the ICU AW Severity Index, range 0100, are employed. An MRC SumScore less than or equal to 36 corresponds to severe weakness with a mortality odds ratio equals 3.2, multivariate analysis, 2020. Diagnosis. A stepwise algorithm is recommended by the Society of Critical Care Medicine, SCCM, 2018 Guideline. 1. Screening, Day 3-5 perform bedside MRC assessment. An MRC SumScore less than 48 triggers further workup. 2. Laboratory panel, key points, CK, 30200U/L, reference, values greater than 250U/L suggest CIM but are present in only 22% of cases. Serum electrolytes, Mg less than 1.7 mg per deciliter and K less than 3.5 millimoles per liter are associated with neuromuscular irritability, sensitivity equals 68%. Inflammatory markers, CRP greater than 150 mg per liter and IL-6 greater than 200 pg/ml correlate with ICU AW development, AUC equals 0.78. MRC SumScore, less than or equal to 48 indicates ICU AW. Management and treatment. Immediate stabilization focuses on airway protection, hemodynamic monitoring, and avoidance of further neuromuscular insults. Targeted parameters include maintaining mean arterial pressure greater than or equal to 65 millimeters of mercury, SpO2 greater than or equal to 92%, or PO2 greater than or equal to 60 millimeters of mercury, and temperature less than or equal to 38 degrees Celsius. Sedation should be minimized, a Richmond Agitation said. References. 1. Heiser S.L. et al. Intensive Care Unit Acquired Weakness and Physical Rehabilitation in the ICU. BMJ, Clinical Research Edition. 2025, 388, E077292. PMID, 398704117, https://pubmed.ncbi.nlm.nih.gov/398704117. DOI 10.1136/BMJ 2023-077292. 2. Team Study Investigators and the ANZIX Clinical Trials Group et al. Early Active Mobilization During Mechanical Ventilation in the ICU. The New England Journal of Medicine. 2022, 387, 1917-47-1758. PMID 3628626, https://pubmed.ncbi.nlm.nih.gov/362866256. DOI 10.1056/NEJMOA 22098083. 3. Othman S.Y. et al. Effect of neuromuscular electrical stimulation and early physical activity on ICU-acquired weakness in mechanically ventilated patients, a randomized controlled trial. Nursing in Critical Care. 2024, 29, 3584-596. PMID 379843373, https://pubmed.ncbi.nlm.nih.gov/379843373. DOI 10.1111/NIC.13010. 4. Rosa D. et al. The Effects of Early Mobilization on Acquired Weakness in Intensive Care Units, a Literature Review. Dimensions of Critical Care Nursing, DCCN. 2023, 42, 3146-152. PMID 3699635, https://pubmed.ncbi.nlm.nih.gov/369963559. doi 10.1097/DCC.0000000000000575. 5. Formenti P. et al. Combined effects of early mobilization and nutrition on ICU-acquired weakness. Nutrients. 2025, 17, 6. PMID 402929494. https://pubmed.ncbi.nlm.nih.gov/402929494. DOI 10.3390/new170611073. 6. Patel B.K. et al. Effect of early mobilization on long-term cognitive impairment in critical illness in the USA, a randomized controlled trial. The Lancet. Respiratory Medicine. 2023, 11, 6563-572. PMID 366934000. https://pubmed.ncbi.nlm.nih.gov/366934000. doi 10.1016/S2213-2600, 22-00489-1. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.